um, practice question number 1B precisely. So the question goes as follows. A 36-year-old man who recently got divorced took 15 grams of acetaminophen 2 hours ago because he felt his life had no more meaning. He had a rethink that there could be light at the end of the tunnel, so he presented at the hospital. The first STEM question for this question is, what are the stages of acetaminophen toxicity and their manifestations? The second one is, list 3 complications of acetaminophen toxicity and what investigations you will use to diagnose them. And 3, how would you treat this patient? So I'll start with the first question. What are the stages of acetaminophen toxicity and their manifestations? So the stages of acetaminophen toxicity are stage 1. The stage 1, the time is in between 0 to 24 hours, which is known as a preclinical stage. And it's the signs and symptoms of this stage is general malaise, nausea and vomiting, diffuse abdominal pain, possibly asymptomatic, minimal signs and symptoms, normal liver function tests, possibly at this stage. Then we have stage 2, which is in between 24 to 72 hours, which is the hepatotoxic stage, which there's right upper quadrant pain, possibly in these patients. Clinically asymptomatic, possibly. So the liver enzymes, such as your AST and ALT, begin to rise at this point, and you're possibly bilirubin. You also have coagulopathy also at this point, in which your PT, your PTT, INR may also increase if there's severe injury at this point. Then leads us to the third stage, which is 72 to 96 hours post ingestion of the acetaminophen, which is hepatic failure with encephalopathy. Liver function tests then peak at this point. Clinical signs and symptoms of liver failure are evident at this point, which is evidenced by jaundice, vomiting, GI upset, coagulopathy, encephalopathy, metabolic acidosis, pancreatitis, possibly acute renal failure also, possibly at this point. Then that leads us to the last stage, which is stage 4, which is greater than 96 hours, in which at this point the patient survives or there's death at this point. So it is so what happens at this stage is full resolution of hepatotoxicity or multi-organ failure and death. So those are all the stages of acetaminophen toxicity. So the next question is, list 3 complications of acetaminophen toxicity and how and what investigations would you use to diagnose them? So I started with the most obvious one, of which we talked about stages first. So I'm going to talk about the phases here. So we have the phase 1, which is, so there's the difference between stage and phases from what I saw in some of the guidelines. I think it was more specific in phases here when we're talking about the actual value of the liver enzymes here. So phase 1, it was 12 hours post-injection, where you have your LFTs show subclinical rise in serum transaminases levels, that's your ALT and your AST. Then you have phase 2, which serum studies reveal elevated ALT, AST, and bilirubin concentrations, and also your prothrombin time. Then you have your phase 3, which shows severe toxicity with lactic acidosis, prolonged PT or INR, marked ALT and AST elevation, which is usually greater than or equals to 10,000 international units per liter, elevated total bilirubin level of more than 4 milligrams per DL, hypoglycemia, anemia, and when you do a biopsy of the liver at this point, you have centrilobular necrosis in the liver. So you can also have encephalopathy, which can also be seen in acute liver failure, and that's presence of altered mental states. And the investigation you want to do for these patients include your serum ammonia. According to the studies I read, arterial serum ammonia concentration is actually higher than venous ammonia in patients with acute hepatic failure, and is more predictive of neurological death, that's brain neuron death. So the brain imaging that you want to do besides your serum, after you do your serum ammonia, you might want to do brain imaging also for this, and you want to do a brain CT, which will show cerebral edema. And if you want to be more specific, you can also do a brain MRI, also that will show the cerebral edema. Then we now have another complication known as renal impairment, which is acetaminophen-induced nephrotoxicity, which is a form of acute tubular necrosis in in these patients, which is as a result of the acetaminophen on the kidney. It said that also that acetaminophen, as it reduces the stores of as it acts on the liver, also it acts also on the kidney, but not as acutely. And it happens in phase 2, like I mentioned before. That's in between 24 to 72 hours. That's when you start having nephrotoxicity in the kidney, and it is evidenced by elevated urea and creatinine, and also in urinalysis, also you can see proteinuria and hematuria in these patients. And it's important to know that this is more acute than hepatorenal syndrome, which is a progressive decline of renal function. The third question now is, how would you treat this patient? So it's going to be important for us to first define what is going on with the patient first, because it's going to help us with the numerous guidelines that are used in management of acute acetaminophen poisoning. So acute ingestion of acetaminophen is defined as a history of known or suspected acute ingestion of 7.5 grams or more acetaminophen within 24 hours of admission. And this according to the emergency medicine guideline that's the American guideline. And this was released in August 2023. But the hepatology guideline says that acetaminophen overdose is based on a history of ingestion of excessive doses, usually greater than 4 grams, as a single time point, which is very important because you want to separate this from subtherapeutic acetaminophen ingestion that can then lead to variable severity of acute hepatocellular liver injury with towering transaminase levels of greater than 1,000 international units per liter within the first 24 hours as observed. And this was also the guideline that was released in March 2023. So how would you want to treat this patient? So the principles of management here first will be your supportive management, then your gastric decontamination, your antidotal therapy, and your psychological support, because obviously the patient needs a suicide watch. Since the patient tried to kill the person, since the patient tried to commit suicide. So first things first, the doctors that will be managing this patient is going to be multidisciplinary. Your first contact, obviously, is going to be the emergency doctor or the emergency physician. Then you have your toxicologist, your gastroenterologist, your psychiatrist, which is very important, nephrologist, your transplant physicians, especially if the patient starts having acute fulminant hepatitis, and your anesthesiologist if the patient is ICU care. But I'll be talking more about this index patient. So immediately at presentation, I would like to assess the patient's airway, breathing, hemodynamic stability, blood pressure, pulse, essentially the ABCs of management. I like to give fluids, check for blood sugar because of management of hypoglycemia, give antiemetics if the patient is currently vomiting, ensure samples for baseline investigations like a full blood count, EU creatinine, viral markers, for the patient, especially your hepatitis screening for the patients, because that will worsen the patient's prognosis. I also want to do a liver function test and a PTINR for the patient, especially for prognosis and knowing how to manage. Simultaneously, as I'm doing all of this, I would like to initiate treatment for the patients. So we'll start with gastric decontamination. Since ingestion of this is going to be the timestamp for ingestion of acetaminophen also is very important. Since it's 2 hours, that means it's less than 4 hours. And acetaminophen is known to be at its highest absorption serum level at 4 hours, and absorption is almost complete at 4 hours. Since ingestion is less than 4 hours, while I await, according to the guidelines, while I await the sample that I have taken, I would like to do a gastric decontamination. And that will be with activated charcoal. And the dose of this is going to be at 1 gram per kg, 25 to 100 milligrams orally, and a maximum dose of 50 grams if within 4 hours of ingestion, of which this patient falls into that category. And this is according to the emergency medicine guideline. Also in the hepatology guideline, gastric lavage also can also be used in some cases, which was not in the emergency medicine guideline. Serum acetaminophen concentration is important to measure even in the absence of symptoms because of delayed onset of clinical toxicity. This is particularly important in patients that took extended release acetaminophen, which you know that the peak onset of action in those drugs is about 8 hours. So for this index patient, I'd like to take my serum acetaminophen concentration. And since it was taking less than 4 hours, that serum acetaminophen, which is important, concentration cannot be used to re-stratify the patient with the nomogram, which your Romac Matthew nomogram, which I'll be talking about in the next slide. So you could take that, and a non-detectable concentration at 2 to 4 hours, which this patient falls into after injection, typically excludes significant injection. However, there's a caveat to this. Both consultation with the poison center and toxicologist is recommended for those patients. Clinically, for this, my index patients, clinically and biochemical evidence of toxicity. If I can see any of them, that's evidenced by maybe altered sensorium, elevated AST, ALP, AST or ALT or elevated iron. I would like to start my acetylcysteine in this patient, despite the fact that it's less than 4 hours. So this is a nomogram. This is a flow chart, sorry, from the emergency medicine guideline from August 2023 on the updated management of acetaminophen poisoning in a medical facility. So I'll start from here and I'll be talking precisely about the index patient. So we know that the history is reliable and accurate here. Acute defined as a period of ingestion from 0 to 24 hours, as I mentioned before. So you would like to start with your I would like to start my gastrointestinal decontamination, in which I'm going to be giving the charcoal, the activated charcoal, and this is if it's within 4 hours, and I'll be giving per oral. So in between 0 to 4 hours, I'll also be taking my acetaminophen concentration in these patients. I mentioned before, the notes I mentioned before this, that it is not reliable and is not used for risk stratification prior to 4 hours. But if the patient has clinical signs and symptoms of toxicity, you might want to start your acetylcysteine in these patients. But ideally, when I'm managing this patient, what I like to do is at 4 hours, where I know that it will be at its peak, at least at serum, the serum level of acetaminophen will be at least, I know it will be at its peak at that point, in between 4 to 8 hours. I would like to take another sample at this point to be able to evaluate with this flow chart again, whether the patient is fit for acetylcysteine administration. So this is the Romac Matthew nomogram that I was talking about. So it has been updated before in the previous nomogram, which most people would see online. You see that the high risk point is at 200, but it has been updated to 300 now, micrograms per milliliter. So this is at the point where the patient becomes high risk line. So this is the treatment line, and you see it at 150 micrograms per ml. So when you do a serum, so this is the nomogram that you use to know whether a patient is going to require N-acetylcysteine administration. This is the nomogram you will have to plot for the patient, and this is your treatment line. So, and you see that it starts at 150 micrograms per milligram. So we're going to, and you can see at the lower border here, it's telling you at time of administration. You can see at 4 hours, that's where it is starting from. So ideally, anything from 4 hours, less than 4 hours is not on this nomogram. And that's why that period in time is very, the management there is not set in stone. So that's why you have to look at the patient clinically. You have to also examine the patient with the biochemical parameters that you have to be able to know whether you're going to give the patient N-acetylcysteine prior to this 4-hour benchmark. So if a patient comes in, and if I now do my serum acetaminophen level, and it's at 10, it's in between 10 and my treatment line here. It's just above 10 here and my treatment line here. What I'm going to be doing at that point is that I'm going to do my acetaminophen level again to know whether this patient is going to benefit from acetylcysteine. So if samples of your acetaminophen level drawn between Oh, I can't even see this. Between 4 to 24 hours is above 10 micrograms per mil, as I said before, but below the treatment line. It should be measured again 4 to 6 hours after the first measurement. So now that leads us to our management with your acetylcysteine. So it can be given with, if you find the patient is above the serum acetaminophen level is greater than your 150 and you want to start treating this patient, then you can go ahead and give oral, especially if the patient is not vomiting, and you can give antiemetics. But most people in most guidelines that I've seen and most papers I saw, it was mostly IV dosing that was preferred, especially if they are intolerant or if they are pregnant. And you want to do telemetry as you are giving your loading dose of your acetylcysteine, because it gives tachycardia, and also there could be an allergic reaction to acetylcysteine. So you might want to do telemetry monitoring in between the time they are giving you a high dose N-acetylcysteine. So your loading dose is 150 milligrams per kg load over 15 to 60 minutes. And ideally, you should be given in dextrose water, followed by 15 milligrams per kg, 12.5 milligrams per kg per hour over the next 4 hours. Then 100 milligrams per kg, 6.25 milligrams per kg per hour over 16 hours. Then thereafter, a total of 300 milligrams per kg over 24 hours. For those with evidence of liver injury, treatment is extended at 6.25 milligrams per kg per hour until ALT is decreased and INR is less than 2. So if this patient, after I've done the serum acetaminophen level and is greater than 900 micrograms per mil, at that point, the patient is now a candidate for hemodialysis. So hemodialysis is recommended in addition to acetylcysteine in a patient acetaminophen concentration greater than 900 milligrams per mil or greater with acidosis or altered consciousness due to acetaminophen toxicity. So what are the treatment reactions that you can get from acetylcysteine? You can have things like bronchospasm, pruritus, flushing, and urticaria. In these patients that have reaction to acetylcysteine, you can stop the infusion, oxygen therapy, give antihistamines, give your IV hydrocortisone 100 milligrams 6 hourly. You'll restart your acetylcysteine, but then at a slower rate. And you can then, if the patient is still reacting, you can have the alternative of your methionine. Then for you to be able to discontinue the acetylcysteine, the patient has to be clinically well. This is a criteria the patient needs to meet. Acetaminophen concentration, that's a serum acetaminophen concentration, has to be less than 10 micrograms per mil. The INR has to have dropped to less than 2. Serum transaminases must be within normal range, or if elevated, has decreased 25 to 50% from the peak that the patient presented with. And this patient obviously would benefit from a referral for mental health evaluation and follow-up since the patient is recovering from a possible suicidal attempt. So these are my references. Thank you for listening.
Thank you very much. Dr. Enejero, thank you very much for being able to prepare this despite the short notice, and it's a very good one. Thank you. Now is the time to listen for contributions from the colleagues, if any. So any contribution? Let me read something from the chat. Dr. Mahmoudi said, treatment line in UK is 100 on the nomogram. American, Canada, Australia, you only get treatment if it's over 150. Dr. Brown said is a great presentation. Dr. Mahmoudi also said 12-hour regimen gives the same overall dose, but gives it constantly over 12 hours and more anaphylactoid reactions from 21 hours. Okay, there are some other posts from Dr. Mamadou, and many people are saying it's an excellent presentation. So those are the comments from the chat so far. We still entertain. Okay, sir, go ahead. Dr. Omoka Tito, go ahead, sir.
Good morning. Thank you very much, sir. And thank you, Dr. Najero, for the excellent presentation. I have some clarifications. First of all, regarding the definition, you said acetaminophen toxicity begins at about 7.5 grams in 24 hours. So my question is, since most clinicians peg the maximum paracetamol dose is safe for administration at 4 grams per day, do you what's your take about doses between 4 and 7.5 grams for, I mean, if required for patients in severe pain? Are they acceptable? Then the second question is about the Rumakmachi nomogram you showed us. That nomogram doesn't seem to take into cognizance concentrations of paracetamol attained before 4 hours. So what happens if the patient is already attaining, for whatever reason, differences in drug metabolism that are genetically acquired or other reasons, drug interaction? What if the patient is already attaining paracetamol concentrations of 150 before 4 hours? What do we do then? And then I would also just like to ask for my own personal enlightenment, the source of the algorithm you posted on the algorithm for the management you posted. Thank you.
Thank you. Thank you so much for your questions. Maybe I should just start from the back forward. All right. So this, I will paste it on the group, but this is the source. I won't put the link in my references. This is the source of the algorithm. It was straight from the emergency medicine guideline in the US and the Canada. It was released in August last year. So that's where the algorithm and the flowchart came from. Yes. Then you talked about the last question the question you asked after that was about taking into cognizance the patients that might have greater than 150 prior to that 4 hours. So the problem with the guidelines I saw, especially the more recent guidelines, is that that's a very shady area. So what the recent guidelines, the caveat they had about those people in between 4 hours and they had elevated serum acetaminophen, although they said that it cannot be used. But in the emergency medicine guideline, it was clear that if the level is not high, that's how they put it. If the level is not high, in between 2 to 4 hours, then the patient will not benefit from from acetylcysteine, administration of acetylcysteine. But they said that they mentioned that you must also get a toxicologist involved. Bearing in mind that, number one, that there are things like PCM that comes in combinations now. We know that PCM now does not just come by itself. Acetaminophen does not come by itself. Most people that overdose on PCM now come with opioid and salicylate poisoning because they are taking combination medication. So there are a lot of things to put into context. So most times when they come in between that 2 to 4 hours, we are going to be getting serum levels that are not exactly what might be the level, maybe 6 hours later. So it might be normal at that point, and it might be elevated later. But if you have any value that is at 150 in between 2 to 4 hours, it is advised that you should start treatment in between that time. I don't know if because the guidelines are not clear. They are not clear about it. So if you have any value that is in between 150, greater than 150 in between 2 to 4 hours, please you start treatment for the patients if you have taken a sample at that point. I don't even think it's ideal to even wait till 4 hours before you take your first sample. Take your first sample in between 2 to 4 hours. Ideally, you can repeat again. There is nothing against taking the sample again after 4 hours, in between 4 to 8 hours, if the patient took extended release acetaminophen just to be safe. That is the second question. Then the third question you asked, sorry, sir, please, can you please recap that third question? I'm so sorry.
Okay, thank you so much for so far. And the third question was about doses of paracetamol between 4 and 7.5 grams in clinical practice.
Okay, in clinical practice. Wow. Okay. So I'm not sure of this question, but I know that the highest dose we give is 4 grams. So when I saw the guideline and it said greater than 4 grams, I think that is, I don't think we give greater than that. I don't think anybody gives greater than that. So I think they paired this greater than 4 also with transaminase levels. So if you are giving greater than 4 with transaminase level, that is when they talked about acetaminophen toxicity. So I think you are pairing this plus also your liver enzymes being deranged at that point. So when you pair both together, I think that's what makes sense according to the hepatology guideline. I don't know if that helps. I don't know. Maybe our chiefs will be able to help me out here with that question. But 7.5 is obviously toxic. It's obviously toxic at that point. 7.5 is toxic. All right. Thank you.
Thank you, Dr. Jean. Do you have any more opinion on how she answered the question? Or we allow Dr. Mahmoud to come in, maybe you add some explanation. Okay, Dr. Mahmoud, go ahead.
Thank you so much, colleagues. Thank you, Doc, for the beautiful presentation. I just wanted to contribute on some particular points that were a little bit gray. You know, there is no general worldwide consensus on which patient to treat or how not to treat. But there are safety protocols that have been put in place for paracetamol poisoning. And of importance is that when we look at paracetamol overdose or paracetamol poisoning, the first thing we look at is how much is ingested and at what time is ingested. Typically within the first 4 hours, if the patient has a normal, they will tell you if the patient has a normal, what they call now, LFT, INR, you understand? You do not treat, you don't even give them anything. But within the first 1 hour, one thing is very important. The gastric lavage comes in. When you think that this is potentially life-threatening or the patient is having those signs, you must give within 1 hour. That is where gastric lavage is important. Within 1 hour, you don't wait for those 4 hours. But it's the approach to the patient that matters. You see a patient come in, has taken some overdose of paracetamol. You understand? And you examine, you don't just rush to take the samples. You look at that patient clinically, look at the signs, any abnormalities within that patient. If you think that this patient likely is in trouble or had some serious adverse event that might want to come in from this paracetamol, you start the activated charcoal and decontaminate it. That's within an hour. But at 4 hours, you start taking your sample. That's why it's not reflected. So at that 4 hours, you starting your drug, the treatment line, if possibly where you start your treatment. Countries have their differences. So that's where, whether for hours, acetylcysteine has its effect, whereby so within 8 hours. So we are still safe. There's still a 4 hours window. You understand? Problem. So you literally would check your at that 4 hours. It's not when the patient comes to just drag and take blood. No. Paracetamol poisoning, or in terms of all these points, there's normally a toxicology. The doctors in emergency or are supposed to come rule out some of all these plants. I'm just saying this because there are other or poisoning too, of which the toxicology base will give you an idea into. I wanted to state the fact that we see a patient who has had and there's normal what do you call it now, symptoms, blood sample entry. Then of you were trying to do in terms of the classification of drugs. When you have you say there's significant acute you see a patient who has taken more than 10 times. 70 kg man, or greater than 75 milligram per. Then also remember, we talked about is ingested. Some people can take it bulk, some people can take it in staggered dose. You understand? So when you have taken some paracetamol within the first 1 hour, we will now see this acute significant overdose of injection of those tablets. You know, we look at that. Then also you make a point.
So you're breaking. Is it just me? I can't hear you well. Oh God.
Hello, sorry, can you hear me now?
Yes, I can hear you. Yes, yes.
Okay, so significant acute overdose.
Okay.
Per kg. You understand? Taken within 1 hour. That's taking more than 10 tablets in a 70 kg. You have those with staggered, what do you call it now? Paracetamol. Greater than 8 hours. The first one that was taken is a significant acute. So it's very key there. In Nigeria, seem to, how do I put it? I have the, but I think we normally, US on, you follow the US using the UK setting. The treatment line is at 100.
Oh, wow.
Hello.
Hello.
Okay. Some of the posts from the chats. Let me read out. Dr. Adebayo Adeyemi said, "Thank you for the excellent presentation. The 4 hours is because of half-life of acetaminophen, which is 2 to 3 hours. So the peak time for serum concentration is that 4 hours. So samples before 4 hours will not be representative. Guidelines differs from countries." And Dr. Akinwumi said, "Not sure methionine was mentioned as an alternative to N-acetylcysteine." Dr. Ifeoma Ede said, "INR is a better prognostic marker for liver injury than LFT in paracetamol poisoning. Activated charcoal diminishes effect of N-acetylcysteine, and N-acetylcysteine may be given within 4 hours if keep on going. May given if there is evidence of liver damage or time of exposure is not known. N-acetylcysteine only prevent further liver damage." Okay, Dr. Okunmi, I think one of the last posts is other indications for not waiting for 4 hours before starting N-acetylcysteine is 1, injection in staggered doses. 2, when patient can't remember the quantity swallowed. 3, injection in patient with mental illness. Acute and chronic use of alcohol is also important in the history. Thank you for the presentation. So these are some of the posts in the chat. I think we should be preparing for the next presentation. Thank you very much once again. Okay, Dr. Success want to add something. Go ahead, Chief.
Okay, good morning, my teachers, senior colleagues and colleagues. Sorry, I've actually not heard some of the contributions because I kept having issues with my network. Thank you so much, the presenter, for that lucid presentation. I just want to add that, so like some of the comments have been, so it's actually after 4 hours that the samples are taken. So you take, because of course that's when we know that the metabolism of, acetaminophen occurs, that we can actually sample to get, so that's why we take it after 4 hours. Then about the charcoal, yes. So I know that some articles will say within 4 hours, but please, most of the time it's within 1 to 2 hours. Okay, so like even in the exam, they didn't want to hear that 4 hours. So some of the articles will say within 1 hour. So I just coined it, to be the safe place. I just said, okay, so if this patient comes between 1 to 2 hours, okay, so you want to, of course, you do supportive care. Then if between 1 to 2 hours, you give your charcoal, activated charcoal. Then, of course, after 4 hours, when you have done your acetamin levels, and of course, using the monogram and it's significant, then you now give the N-acetylcysteine. So that's what I said, and I saw them giving the marks. Now, I don't know, maybe those that went for the exam too can also comment. Now, for the complications, what I said was, yes, I thought of the hepatotoxicity, okay, acute kidney, liver injury. The second one I talked of was, of course, acute kidney injury. And then the third I talked of was encephalopathy. And funny enough, they did not agree with me, encephalopathy. So the examiners were like, yes, okay, so it's not from the liver injury. So what else? What else? I tried to say all the things in my eyes. Okay, this patient is depressed and maybe psychosocial issues. Maybe the patient may be having some psychiatric. They said, no, what else? They just said it's around the liver. If you say it, will allow you to go. Funny enough, I didn't say. That was the only thing I didn't say in the, because I thought I said the encephalopathy as a third complication, but they did not agree. So it was later I was now saying that maybe I would have said something like pancreatitis or something, okay, because they did not agree with the encephalopathy. Then I also want to say lastly that the speaker, you did very well. But there's something that Christabel used to say, and I actually applied it in the exam, and it works. Now, most of these questions, they just want you to tell them what they want to hear, and they will mark. Okay, so if you'll be used like 10 minutes to do this presentation, it means that if we do it in exam, we may not exhaust that station before and getting the optimal mark. So it's important that each time we are given a question to answer, please let's just go ahead and answer that question. Then subsequently, if you want to do discussions, we can now say, okay, I just want to talk briefly about it. But please let us go ahead and answer the questions, because this is very important. So that we will, since this is exam we are preparing for, we'll be exam conscious, utilize that station and get the maximum mark before going to the next station. Thank you so much for the opportunity.
Thank you, Chief Success, for adding much of your experience to this question. Thank you very much. We appreciate your presence and comments. I think we should prepare for the next, but Dr. Alison Orimoladi want to add something again. I think probably
Yes,
maybe the
thank
last
you.
before the next, because we are running out of time. Go ahead, ma'am.
No problem. It's just thank you so much. Good morning, our teachers and everyone. It just to add that in answering the questions, the examiners were also interested in the psychiatric issue of the patient. We are expected to mention that the multidisciplinary treatment with the GIT. You mentioned the clinical pharmacologist, and you mentioned the psychiatrist or psychologist, as the case may be. It was important in my exam. Then you now mention what you will do after, because this patient is divorced, stays alone. So those parts of treatment, even because they said, how will you manage this patient, even up to discharge? That was how the question was. I'm not sure if the recall was like that. So till discharge was what they asked. So you need to fathom the social issues of the patient. And because if you discharge the patient without sorting out that, patient will go back to the same abuse. So you have to sort that out. And the home environment, they said the patient stays alone. So those are part of the issues that we were expected to manage in the exam. Thank you.
Thank you very much for this contribution. Thank you. We appreciate. Dr. Ogundari Adewale should share his screen, please, for question number 1E. But it's like I did not see him in the platform. I don't know. Okay. Dr. Ogundari Adewale, please. In his absence, we can answer the question together in the next 20 minutes. So can somebody share the question from the platform?
Dr. Yahya, there's
Yes,
no
ma'am.
need to do that. Let's answer number 3.
Okay.
Let's question number 3. We just select this paper. And so if it doesn't answer, maybe as we are running on paper, then we come back and answer it.
Hello, good morning. Good morning, my teachers and colleagues. Can I go ahead and present my own question?
Okay, go ahead. I've started sharing too, but go ahead, please.
Okay. Okay, good morning. My name is Dr. Ndiong Oka, and I'll be answering question 2B. And the question says, an elderly woman presented with malaise and poor feeding. She was incoherent at presentation, and her husband had to give the history. She went to bed early the day before, saying she was not feeling well. She has non-Hodgkin's lymphoma, and her last chemo section was 3 weeks ago. She had background hypertension, type 2 DM, and hypothyroidism, which were well controlled. Her medications include metformin, bisoprolol, captopril, allopurinol, levothyroxine. She is hypoxic with SpO2 of 86% on room air, which improved to 92% after she was placed on oxygen, and her BP was 96/54. The pulse rate was 122 beats per minute. And her investigations results were as follows. The hemoglobin was 8.6 grams per DL. WBC was 0.6 times 10 raised to the power 9 per liter. Neutrophils 0.1 times 10 raised to the power 9 per liter. Platelets were about 46,000, and the urea and electrolytes were said to be normal. CRP elevated. Well, that's how I got the question. And the first question was, what is the diagnosis? So looking at the scenario and the lab parameters made available to us, I made a diagnosis of pancytopenia, probably secondary to aplastic anemia in this patient. Could also have a viral infection that may have also precipitated this condition. We're also asked to list additional investigations needed in her management. I think this patient will need a peripheral blood film that will help to distinguish the aplasia from other infiltrative diseases, where we expect to see.
Can you put it on slideshow, please?
Oh, sorry. So I would like to do a peripheral blood film to help to distinguish the aplasia from infiltrative diseases, and expect to see things like teardrop cells or poikilocytes or other leukoerythroblastic changes that may suggest infiltrative process. I also want to assess for fetal hemoglobin in this patient, since she has anemia, meaning that the red cell line is affected. Usually when there's aplastic anemia, the fetal hemoglobin production also increases. This patient may also have an abnormal liver function test that may indicate an antecedent or ongoing hepatitis, as well as present with features that are suggestive of active hemolysis. when, like, if the transaminase, the bilirubin is elevated. I will also want to do a Coombs test in this patient. A positive Coombs test will point to hemolytic anemia in this patient. Other serologic tests for hepatitis and viruses like Epstein-Barr virus, CMV, and HIV could also be useful in investigating this patient. A bone marrow aspiration and biopsy would also be done for her to assess the cellularity of the bone marrow, looking at the qualitative and quantitative nature of the cells. And then an MRI will show the overall bone marrow cellularity, because sometimes an aspiration there could be pockets of hypercellularity in the bone marrow, and the aspiration may actually go and pick up these pockets, giving a false picture of a depressed bone marrow. So the question says as well, how will you treat this patient? Well, for aplastic anemia, which we'll manage in this patient, first, there will be the supportive care. And I would like to say that it's a multidisciplinary approach. We have to involve the hematologist, the oncologist, and then probably knowing that this patient has other comorbidities of, she has hypothyroidism, type 2 DM, and I think hypertension as well. I will also want to invite the endocrinologist and also probably the cardiologist to manage this patient. She will need supportive care with transfusion of packed red cells and platelets. So, but it's important to avoid transfusion from family members because of possible sensitization against non-HLA tissue antigens of potential donors that could come from the family members. I also want to treat the infections noted in possible infections in this patient that may have also tipped her into having this condition. So we could use antibacterials or antifungals or antivirals as required. And then immunosuppressive therapy is also said to be used as a first-line therapy, but that depends on the staging of the aplastic anemia. And then ultimately, a hematopoietic cell transplantation is also offered for management. So briefly, I just want to talk about aplastic anemia. It's a syndrome of bone marrow failure characterized by peripheral pancytopenia and marrow hypoplasia, and it develops as a result of bone marrow damage. This damage can be present at birth or occur after exposure to radiation, chemotherapy, toxic chemicals, and some drugs or infection. In our index patient, she's on chemo, and the CRP was said to be elevated, which possibly may mean that she may have had some viral infections as well. There are two types, be a primary idiopathic aplastic anemia or secondary acquired. For our index patient is an acquired aplastic anemia, and these are some of the etiological agents. Drugs, particularly cytotoxic drugs, are implicated in causing acquired aplastic anemia. Antibiotics, anti-rheumatic agents, anti-thyroid drugs, anticonvulsants, and some immunosuppressive drugs. Also, some chemicals have also been implicated in causing acquired some chemicals have also been implicated in causing acquired aplastic anemia, radiation infections, pregnancy, and then paroxysmal nocturnal hemoglobinuria. So the International Aplastic Anemia Study actually staged severe aplastic anemia to be severe aplastic anemia when the marrow cellularity is less than 25%, plus at least 2 of the following peripheral blood films: neutrophils less than 0.5 × 10⁻⁹, platelets less than 20, and the reticulocytes less than 24. The index patient had neutrophils less than 0.1, but she had a platelet greater than 20,000. And then very severe aplastic anemia. The marrow cellularity is less than 25%, and the neutrophils less than 0.2, platelets less than 20%, reticulocytes less than 20. So we're not giving reticulocyte count in this patient. For non-severe, is defined as aplastic anemia that does not fulfill the criteria for severe or very severe. So for additional notes in the treatment, as I had stated earlier, the British Committee for Standards in Hematology recommends that a prophylactic antibiotic and antifungal agents for patients whose neutrophils count are less than 0.2. So they advised a prophylactic treatment for patients like that. Then immunosuppressive therapy with anti-thymocyte globulin and cyclosporin is said to be first line for severe and very severe aplastic anemia for those who are older than 50, or if the patient is between 30 to 50 years of age in the presence of comorbidities. We're not told the age of the index patient, but if she's between 35 and 50 in the presence of comorbidities, she would use the immunosuppressive treatment as a first line. Then it's a second line therapy for younger patients if the HLA matched sibling donor is not available. Immunosuppressive therapy is also recommended in patients with non-severe aplastic anemia that are transfusion dependent. So they also mentioned diet and activity in managing these patients with aplastic anemia who have neutropenia or receiving immunosuppressive therapy. And it should be tailored to exclude raw meat and dairy products of fruits and vegetables that are likely to be colonized by bacteria, fungus, or mold. The patient should also should avoid activity that will increase the risk of trauma during periods of thrombocytopenia. And the menstruating women are also advised to be on hormonal treatment to avoid menstrual cycles that are likely to be heavy due to thrombocytopenia. These are my references. Thank you.
Yeah. Thank you, Dr. Ijama, for putting up this thing despite the short notice. Thank you. It's a very good one. Even though I think some of the colleagues and senior colleagues were thinking it's neutropenic sepsis. However, you educated us on aplastic anemia, and I think the room is there for us to discuss more. Thank you very much. Well done. Dr. Tanimu want to say something. Go ahead, sir.
Thank you very much for this presentation. I think the recall was incomplete. There was fever and the value of the temperature. That is why she is diabetic. Because it's like it's neutropenic sepsis. So that fever that was missed during the recall and the value of the fever maybe is the one that diverted her mind to
Dr. Tanimu, I don't think it was missed. Dr. Tanimu, it was not missed. Dr. Tanimu, it was not missed in the recall. You were part of the recall now. Doctor, the presenter, please, can you show us the question? I didn't want to interrupt her at the beginning. It was neutrophilic sepsis. I just wanted her to express herself. That's the essence of the discussion.
Well, I didn't see the one that was sent. I didn't see any history of fever. So I have some typos, but
even if there was no fever, even if there was no fever, we know that sometimes even diabetic patients or people that are immunosuppressed, sometimes they don't mount enough immunity to give you fever. Do you understand?
Yeah.
So that it still doesn't rule it out. You know, when you see a question that is a little funny, you know, national, I don't know, they can't just bring a aplastic anemia like that. They always want to look at an aspect of aplastic anemia, just like it might not just bring lymphoma for you. They just do for one aspect, is that history or ethics. You know, these things are wide because say aplastic, how would you manage it in a few minutes in exam? So you look for an aspect of it for you. But as I said, this is you did a good job, really.
Hello? Hello?
Go ahead, sir.
Sorry. Okay, thank you. Yes, thank you very much, Dr. Ndionoka. Yes, even given the question like Dr. Christabel said, I think neutropenic sepsis is really what this question is focusing towards. But I think one of the things that could have helped is that the differentials could have been more. I think it could have been considered in the differentials, even if maybe you didn't see the fever in the question. And of course, fever is not a sine qua non prerequisite for diagnosing neutropenic sepsis. And I also think there could have been other differentials that should be coming to the mind in the setting of non-specific symptoms, malaise, poor feeding in a patient with a known malignancy on chemotherapy. So especially with the blood counts, another differential that should come to mind should be myelodysplasia. But myelodysplasias commonly present with cytopenias, blood cytopenias. Rarely it can be pancytopenia, but usually the cytopenias will affect one or two cell lines, either the platelets and white cells and red cells, or red cells and platelets, or just one or two. Then also, since the symptoms were non-specific, you should also consider, superimposed infections like you did. You talked about viral infections, but other kinds of infections could have given her non-specific symptoms like malaise and all that. And then also other tumors induced by the drugs, other tumors. So she's already been treated for one malignancy, but drugs can also, especially cytotoxic drugs, can predispose patients to having other malignancies. Then electrolyte imbalances, especially in the setting of chemotherapy, tumor lysis syndrome, even though the specific values pointing towards that are not given in the question. I'm just saying that maybe an expanded differential would have probably helped us to capture the correct diagnosis, even if we missed it in our main diagnosis. Thank you.
Thank you very much for that addition. Thank you. Okay, let me read from the chat. Dr. Mahmoudi said aplastic anemia is a good differential. Neutropenic sepsis can occur without fever, especially those on chemotherapy or steroids. Dr. Ekele said, thank you so much for the presentation. Please, can you still send the notes for the aplastic anemia different from the question? Those are the things from the chat. Okay, somebody is raising his hand. I can't see the name, but go ahead, sir.
Okay. Good morning. Good morning, everyone. Like other people have said, it was neutropenic sepsis. But since I think Dr. Tanimo talked about fever. From what I can remember, maybe the guideline has changed, but I thought the guideline was that neutrophil count less than 500 per microliter. Then you have temperature of 38 degrees centigrade and above, and then signs and symptoms of clinically significant sepsis. I think those are the diagnostic criteria for neutropenic sepsis. And I think that was the way it came out in the exam, like Dr. Tanemo said. The temperature was about 38 point something. In fact, once you see it, if you know about neutropenic sepsis, that's the first thing that will hit your mind. And they were not asking for differential diagnosis, just the diagnosis exactly. And once you mention it, they just tick it, So I think that is it. So, but if the differential, if the guideline has changed, the guideline as to how to diagnose neutropenic sepsis, that you don't need fever, I think maybe somebody can just put it, maybe the presenter when she's submitting the slides could just put it, maybe the latest guideline on neutropenic sepsis. But from what I know, fever is one of the criteria. This was as far back as 2019, so maybe things have changed now. Then in the exam, from experience, once they've diagnosed something for you, for example, I mean, the presenter talked about bone marrow biopsy and all those things. I remember I mentioned those things. The examiners will tell you that the diagnosis is known already. The patient has non-Hodgkin. In fact, they will emphasize it, so they don't want you to re-diagnose the patient. But I think because she was thinking the line of aplastic anemia, so she went to town about diagnosing it. So usually once they have diagnosed like that, just mentioning how to diagnose again might not really, it won't hand you any mark. So just go ahead and, except maybe somebody did CT scan for somebody now, for example. I think maybe that was in some specialty, maybe in some other place. You could go ahead and do a brain MRI. So if there's a superior investigation that could help you to nail the diagnosis better, or for better therapeutic choices, then you could say it. But in this patient, bone marrow biopsy was not accepted, at least in my own with my own examiners, since they said the diagnosis is known and the patient is even on chemotherapy already, so they didn't take it. Thank you.
Thank you, Chief, for your experience. Thank you very much. Dr. Alison Orimolade, want to say something again? Please go ahead.
Yes, thank you. Let me just say some things I think might help. During the exam, they will ask you to read the questions very well. So even if you are reading it for 2 minutes, that's not their headache. They will tell you to speak to them when you are ready to speak to them. And you'll be opportune to read up to the questions too. So that gives you an idea. So for my station, this patient just had chemotherapy. That was a catch. There was fever. Patient was delirious and stuff like that. So agranulocytosis was top on the list actually, which could also be in line with the neutrophilic sepsis that we're talking about. So definitely, and we're giving C-reactive protein in this patient, which was severely elevated. And they put the normal in brackets, normal values in brackets. So you are actually expected, after giving the agranulocytosis with sepsis, you now look for the focus of the sepsis. That was just the only catch. And the investigations they were requested, they were interested in, blood culture, urine culture, sepsis workup generally were the main things that was needed in the station. And then in management of those patients, you should be able to, because this patient was on gamut of medications and patient had so many comorbidities. You must mention the multidisciplinary approach, just the way we've been learning on this platform. You must mention the hematologist, mention the renal, clinical pharmacologist, endocrinologist, all the things that the patient, the comorbidities that the patient has. The patient will be managed in an ICU setting or high dependency units. I also mentioned that the patient will need like a barrier nursing. This patient literally does not have white blood cells. So not everybody will be opportune to touch the patient. So the patient must be barrier nursing was important too. Another thing that was important in the management of the patient, because when I mentioned the antibiotics, they specifically asked that empirically, then even when I mentioned ketrazone and metronidazole, they still asked again which other one. I had to mention meropenem. So all these antibiotics are very strong that will cover all forms, especially putting in consideration these patients was important. Another thing that was important is this patient vis-a-vis the platelet was not so high. And prophylaxis anticoagulation was equally important because I was asked. Then when I had talked about transfusion, they will ask you what exactly are you transfusing? Fresh frozen plasma, full blood, and full whole blood were the things they were asking. So all those should be put into consideration just to an addition to help. Thank you.
Thank you, Chief. Well done. Thank you. There are some few chats from the box. Let me read out before handing over to Dr. Christabel. Dr. Igwen said, what of agranulocytosis due to cytotoxic drug? And somebody said, Dr. Mahmoudi said, absolute +1 criteria. Also, neutrophil count of less than 0.5 times 10 to the power 9 per liter or lower, +1 of the following. He's trying to define the current definition of neutropenic sepsis. So a neutrophil count of less than 0.5 times 10 to the power 9 per liter, +1 of the following: temperature of greater than or equal to 38 degrees Celsius or other signs or symptoms consistent with significant sepsis. So thank you. Those are the comments from the chat. I think we'll hand over to Chief Dr. Chris Abel. Thank you all. Thank you, the presenter.
Thank you. Thank you, Dr. Yahya. Thank you, the presenter. The two presenters was quite a wonderful presentation. The last presenter, what you do for us, please, you will kindly answer the question as leave the aplastic anemia, because we never can tell where